This is Rick Mattson from the University of Washington Shoulder and Elbow Service. Let's talk a little bit about how to do a CTA arthroplasty. First of all, cuff tear arthropathy is the condition in which the arthritis of the glenohumeral joint is combined with a rotator cuff deficiency. And one of the hallmarks of this particular condition is contact between the humeral head and the acromion. Of course, normally the rotator cuff runs through this interval, but in cuff tear arthropathy, typically there's contact between these two bones, which means that there's no rotator cuff in between them. Here's some other x-rays showing sort of the classical appearance of cuff tear arthropathy, and we're showing with the blue arrows the unphysiologic contact between the acromion on the top and the humeral head beneath. And you can see in many of these cases the humeral head is displaced upward some with respect to the socket, and it is come in contact with the acromion at the top there. So we consider what we call a CTA arthroplasty when a person has symptomatic rotator cuff tear arthropathy, but their shoulder is stable and they have the ability to raise their arm up above the horizontal, as is shown here. And the CTA prosthesis has an extended head, as I'll show in a minute, that allows for articulation of the upper aspect of the prosthesis with the undersurface of the coracoacromial arch. This procedure is particularly attractive to folks who desire higher levels of activity that may be possible with a reverse total shoulder, or alternatively people who are at high risk for falls, which might endanger a reverse total shoulder. So the special thing about the cuff tear arthropathy prosthesis is it has this extra bit of articular surface for covering the area of the humerus that has become uncovered by the absence of the rotator cuff attachment. So the dark blue here shows the standard humeral head prosthesis, and here is the extra bit that makes it a CTA prosthesis, shown here and here. And this special addition to the prosthesis, shown on your right here and here, allows for smooth articulation of the humeral head underneath the coracoacromial arch that may not be possible when you've got a standard prosthesis and bone extending beyond it, as shown here and here. Now, a CTA arthroplasty won't work in shoulders that are unstable. So here's a diagram of a shoulder that has anterosuperior instability. In other words, the ball slides out of the socket and up, as is shown by this patient who's trying to elevate their arm but can't do it because the ball just moves upward, as shown here. In this situation, a CTA arthroplasty will not work, and a reverse total shoulder is what's needed. So, in the patient that does meet the criteria of intact active elevation with cuff tear arthropathy, let's go through a few of the key steps of the operation. So we use the relaxed beach chair position that enables the arm to be moved freely. We make a deltopectoral incision along the line connecting the coracoid tip and the mid shaft of the humerus, as shown here. We split the deltopectoral interval and take the cephalic vein laterally. And then we split the clavipectoral fascia, as shown on this dotted line, just lateral to the coracoid muscles, and be sure and stay on the safe side of those coracoid muscles as opposed to the suicide on the other side. We preserve the we preserve the circumflex vessels and proceed to isolate the axillary nerve so that we can protect it during the exposure. And a critical step in this procedure is to keep the coracoacromial ligament, as is shown here, and the extension of the clavipectoral fascia, which extends down from it. We call that the CA plus, or the coracoacromial plus, because that ligament plus this fascia provides stability for the humeral prosthesis, as is shown here, preventing anterior instability. The subscapularis is taken down with a peel off the lesser tuberosity as shown here. We expose the humerus by placing a smooth Darrow retractor behind it, and we make the cut on the proximal humerus at 45 degrees with the long axis of the shaft. We then need to make this little extra cut here to accommodate the extended humeral head part of the CTA humeral head. When we prepare the humeral canal, we're very careful to put the medullary reamers down just to the point where we get a little bit of a bite down here. We want to carefully avoid an endosteal notch here, which can weaken this bone. This is particularly important since many of the patients needing this procedure have some degree of osteopenia or osteoporosis. We also are very careful not to use too big of a broach in preparing the humerus because we don't want to crack the metaphysis here. So if there's any question, we can just downsize the broach, and then, as you'll see, we can fix it using impaction grafting. We want to measure the head diameter of curvature using cutout guides so that we can duplicate that diameter with our prosthesis. So here are some examples of measuring the humeral head diameter of curvature at surgery. When we're selecting the prosthesis thickness, we want to make sure that the trial component gives us a little spring. So when we push the arm into the side and then suddenly release, we want that arm to jump about 30 degrees out from the side. The prosthesis has several thicknesses, 13, 18, and 23, so we can select among those the one that gives us that proper degree of spring. What we want is a thickness that will also tend to relocate the humerus back in the glenoid. So here's a normal humeral relationship with the glenoid. Here is the humeral head displaced upward, sort of breaking this arch. And here is the properly selected humeral head implant that restores the arch, indicating normal relationships with the glenoid. We need to be careful to remove any unwanted bone laterally or medially to make sure it doesn't contact the glenoid here or the acromion here. When we're ready to fix the stem, we can use bone harvested from the resected humeral head for impaction grafting. Almost always there is a subscapularis to repair, so we put 6 holes and 6 sutures in the anterior neck cut. If the biceps is not intact or unstable, we can do an inside-out biceps tenodesis by threading the biceps through a hole in the humerus and leading it out through the canal so that when the prosthesis is put into place, it'll pin that tendon exactly in the right spot. When we put the prosthesis in, we want to be careful that we avoid contact with the skin, and we want to make sure that it is, once in place, is seated properly in the glenoid and beneath the coracoacromial arch. Here's some examples of the CTA arthroplasty, seeing a patient that had a failed prior cuff repair as indicated by the suture anchor. You can see that the CTA arthroplasty is intact. Here's another example, again, non-anatomic contact between the humeral head and the glenoid. Now that's been resurfaced with the CTA arthroplasty. Here again, superior displacement of the head preoperatively, and then nice recentering of the head in the glenoid after surgery. So here are 2 ladies who had this operation done, each of them 9 years prior to these photographs, and you can see that they have active function of their shoulder without problem and without the risks associated with a reverse total shoulder. Here's a study where we published results of 42 patients. Here's an example here showing the humerus before surgery with a lot of deformity. Here it is 3 years after surgery. None of these patients had component dissociations, base plate failures, or dislocations. And you can see that using the parameters of the simple shoulder test, they were dramatically improved, postoperatively shown in red compared to preoperatively shown in blue. Thank you.